Good afternoon for West Coast and good evening for the East Coast. So today's topic is treatment options for pain in myotonic dystrophy. So let's go to that topic today. First is disclosure. I have nothing much to disclose, but I serve for Medical and Scientific Advisory Committee of Myotonic Dystrophy Foundation, but I don't receive any money from them. And I have a grant funding for the Myotonic Dystrophy Clinical Research Network from MDA, Muscular Dystrophy Association, through University of Rochester. And finally, I receive also NIH R01 grant funding for the basic science research. Let's go to the next slide. So I'm going to start with a story of a patient with myotonic dystrophy. This is a pain-related story, and it's very important. So just bear with me to listen to the story. I'm going to read this. And so the patient is a 48-year-old woman with a diagnosis of myotonic dystrophy type 1. And she was presented at the emergency room of a hospital because she fell and noted excruciating pain in her left leg. She thought she broke her leg. So she started to have myotonia of grips in her teens. I'm going back to the history of myotonic dystrophy, and noted difficulty standing on her toes a few years later. So that indicates that she had myotonia and weakness, particularly in distal muscles, hands and feet. She also had a problem with opening a jar due to weakness of her finger muscles, particularly the finger flexors, sort of a bending of the fingers in very distal end of the joint. That is the first muscle to go in myotonic dystrophy. The weakness gradually progressed with thinning of the distal muscles, particularly in forearm muscles and hand muscles, and also lower leg muscles are becoming thinner. She visited her family physician, excuse me, at age 35, and on the examination, the reflexes were gone, and she was told that she had peripheral neuropathy because average physicians, non-expert, are trained to think about peripheral neuropathy when the reflexes are gone and distal muscles are weaker. However, the diagnosis of myotonic dystrophy was suspected by a neuromuscular specialist who received a referral to perform electromyography, EMG, on her from the primary physician. And then the diagnosis was confirmed with the DNA testing and the EMG findings. The EMG finding is shown below. And so if you insert a needle in normal individuals, you see probably 1 or 2 blips and then become silent. But in myotonic dystrophy patients, you have this prolonged discharges. And this is associated with prolonged contraction of the muscles with failure in relaxation. And later on, so the DNA testing was done, and that DNA showed 650 CTG repeats in myotonic dystrophy protein kinase gene. So that's a disease mutation that I think many of you are familiar with. Next slide, please. So she continued to have slowly progressive muscle weakness, which started to involve proximal muscles in arms and legs, to the point that she had difficulty reaching overhead shelves and had to use a walker now. So distal muscles converted into, spreading into the proximal muscles. That's a critical moment, because when it happens, the patient starts having a real problem in walking. And recently, she was having difficulty getting up from a chair. And when she falls down to the floor, she cannot get up unless there are nearby furniture or somebody else who can help her. And meanwhile, she had a cataract removed from both of her eyes before age 50, which is an early onset cataracts. And her gallbladder was taken out with gallstones. And those were done without complications, but I'm going to come back to that later. But these are the issues because if those surgeries are done under general anesthesia, anesthetic complications may be very serious complications. And she has been receiving annual electrocardiogram without abnormalities. EKG is very important to be repeated annually because that can give us warning signs for more serious complication of the heart, like conduction block and sometimes ventricular tachyarrhythmias, and those can be fatal. And one of the most common causes of sudden death in myotonic dystrophy. Next, please. Next slide, please. So on the day of her ER visit, she fell because of her weakness, and she stumbled on a small elevation of the floor in her house. She immediately noted severe pain in her left lower leg, and her family called an ambulance, and she was taken to the emergency room. In ER, she was suspected to have a fracture of the tibia, that's a small and large bone of the lower leg, and she was given intravenous morphine. That's quite reasonable as an ER routine procedure with excruciating pain. But soon she started having difficulty with her breathing. The ER staff had to intubate and place her on respirator because she couldn't breathe. Her breathing was not deep enough, and she was turning blue, and ABG, arterial blood gas, showed real respiratory failure. And in the process of intubation, she received fentanyl. That's another narcotic medication, opiate medication, that also further suppresses the breathing capacity. In the meantime, X-ray confirms the fracture. Next slide, please. She was treated for the fracture with a cast and admitted to the ICU because of the breathing problem. Usually, fracture itself doesn't require ICU admission. So this is in serious condition, medical condition with a breathing problem. She continued to receive opioids because of the pain, to ease the pain from the fracture, and sedatives for making the breathing easier with intubation. Now, you can imagine when the tube is in your windpipe, it creates a coughing and bucking responses. To suppress that, those sedatives are given, but sedatives suppresses breathing. So following days and weeks, many attempts failed to extubate her because of those sedatives suppresses myotonic dystrophy patients' respiratory center, which is particularly sensitive to anesthetics, sedatives, including benzodiazepines like Valium, Xanax, etc., as well as opiates like morphine, Dilaudid, etc. So she had to receive a tracheostomy, that is sort of cutting the throat and making a hole directly to the windpipe, because endotracheal tube through the mouth cannot stay there too long, just at most probably for a couple of weeks. So after that, tracheostomy has to be performed, and she received that. It took 2 months to finally successfully extubate her. And it took another 8 weeks for her to be able to walk with a walker because she was in bed for a long time, and so she was deconditioned. So it was a very detrimental event for her. Now, this story was totally a fiction. I combined about 3 or 4 cases together to make up this story because I didn't want to violate the HIPAA regulation. But I think there's a mixture of the outcomes. Some people did only a few days of intubation and got out of the hospital. but one patient died actually because while she was intubated, she developed she developed a pneumonia, and then she died from that. And I have received a couple of phone calls from lawyers of the defendant side, which is a hospital, with similar conditions with respiratory failure in myotonic dystrophy patients. And so, this is more common than you think. And indeed, when you have a pain, excruciating pain with any reason, and go to ER, I would like you to tell the ER nurses, ER staff, not to give you IV pain medications. The oral medications are quite all right, and the intramuscular injections may be tolerated much better. But the IV medications could be deadly and have serious consequences. So, of course, you may have to get IV medication, and I would say 90% of the time it is okay, but then you need to have a precaution. Nurses know about the condition of myotonic dystrophy sensitivity in the respiratory center to those drugs. So that's probably the most important message that I would like to convey. But pain management is important, particularly in acute excruciating pain. So sometimes you have to receive those medications IV, but ER staff has to be very vigilant and know about it and minimizing the dose, and the alternative medications have to be co-used to avoid this kind of serious consequences. So here, do not use large doses of parenteral. Parenteral means non-oral, especially intravenous opioids and sedatives for management of pain in myotonic dystrophy patients. However, there have been no formal systemic studies published in the literature on the safety of aggressive pain management in DM1 or DM2. So I think this is a pitfall for, particularly when you visit ER, emergency room, because not many people know about this kind of complications. And some of the patients of mine said, because, after I told them about these stories, and they said, well, ER staff are too busy to listen to the sensitivity of the respiratory center of myotonic dystrophy patients. So to just convey the message, they have told the ER staff that the patient is allergic to opiates. Well, I think it's not exactly correct, but sometimes it may serve the purposes. The period, there is no systemic study of opiates administration in DM1 and DM2 patients, but there are studies about opiate perioperative use in patients with DM1. And here, there's a higher risk for the respiratory failure. RR is a relative risk compared with normal individuals. It's a 7.7 times higher risk for myotonic dystrophy patients, DM1 patients, to have respiratory failure. And 95 confidence interval is 2.2 to 12.8. That means with 95% of being right, the probability of being right, the risk range is 2.2 to 12.8 times higher for the DM1 patients to develop respiratory failure compared with control patients. Okay, next one, please. There are other pains. Most common one is muscle pain. Muscle pain comes in very different, many variable quality and the severity. I'm going to go on that later. Then abdominal pain. One is the intestinal pain due to hypomotility. The guts do not move well. And also, there is a gallbladder pain, which is very common. Now, intestinal pain is usually associated with constipation, and sometimes it presents with similar findings as a irritable bowel syndrome. But sometimes it's as severe as obstruction type of symptoms. In gallbladder, because the smooth muscles in the GI system is weakened, that bile does not squash out from gallbladder very smoothly. As a result, gallstones develop, and if a gallstone is lodged in the outlet of the gallbladder, it gives excruciating pain in the right upper quadrant of the abdomen. Now, the chest pain can happen when the patient has arrhythmias. The most common arrhythmias is relatively benign, but it's called atrial fibrillation. But it gives you fluttering, butterfly type of sensation in your chest. And atrial fibrillation, particularly when the heart goes into atrial fibrillation and out frequently, in and out frequently, it may be the source of blood clot going into the brain, and that can cause a stroke. So it's not a completely trivial situation, and so we need to pay attention. And again, annual electrocardiogram is very important. And sometimes the chest pain is associated with more serious type of arrhythmias, like ventricular tachyarrhythmias, ventricular fibrillation, and ventricular flutter. And those things, if it's prolonged, you lose your consciousness, and the cardiopulmonary resuscitation will become necessary. And complete AV block, and that can also have chest discomfort, and the pacemaker is the necessary treatment for that. So various types of pain can happen in myotonic dystrophy. Next slide, please. So first, muscle pain. The muscle pain is, interestingly, much more common and much more severe in DM2 myotonic dystrophy type 2 patients. But it may be under-recognized in myotonic dystrophy type 1 patients. And usually it's a muscle pain, a sort of an achy pain, and stay in the muscle, but often involves also joints, tendons, and the ligaments. Next, please. So if you look at the pain perception is called nociception, and the receptor of the pain in the body is called nociceptor. Nociceptor consists of what is called free nerve ending, sort of a bare nerve ending in the, for example, skin. And here, the picture illustrates that injury is caused. This is a self-inflicting injury, kind of funny, but the hammer, accidentally hammering the finger. Then this nociceptive nociceptor, free nerve ending is stimulated, that is transmitted through the nerve. You can see this line, peripheral nerve, and going to the spinal cord, and then it transmitted into the brain. And next slide, please. So that's the basic anatomy of any kind of pain. So as I said, nociceptors is a sensory receptors of painful stimuli. In skeletal muscle, it's interestingly, we can't find those free nerve ending. So nobody has found the exact nociceptors in the muscles. But there are papers talking about putative nociceptors. So these elusive nociceptors have to be present because the muscle can sense pains. The well-known pain-causing chemicals are bradykinin, which is a red pepper constituent, chemical component, and also 5-hydroxytryptamine, which is a serotonin precursor. And those can give noxious pain, as well as if you squeeze the muscles very hard, you can feel the pain. So muscle has pain. And interestingly, that the pain is not a very fast transmitting pain, because you may have received some immunization shot in the muscle, usually in the shoulder muscle called deltoid muscle, and you feel the prick in the skin. And the doctor or nurse will deliver the vaccine into your muscle. You may not feel the pain immediately, but 5 seconds, 10 seconds, sometimes a minute later, you start feeling the pain, burning pain in the muscle. So that is a nociceptor stimulation. We don't know what it is, but pain is transmitted. Now, so painful structure is not only in the muscle, but within the muscle, there are connective tissues and blood vessels. So those may be also the painful structure. And also, nociceptor in the muscle is sensitive to ATP, adenosine triphosphate. That's an energy source of the muscle to make the contraction of the muscle possible. And also acidity, low pH. When the muscle works hard, then lactic acid is produced, and that acidity pH goes down, and this acidity may cause a pain as well. Next, please. So this is the nerve in the muscle. What we see is a motor nerve that transmits your will to contract the muscle. You want to muscle to move, then motor neuron send the nerve and end up to a motor end plate. That's a sort of a twig-like structure shown. Those are alpha motor neuron ending. So, but that doesn't transmit the sensation, so it's not really the pain fiber. Only sensory fibers, well recognized, are in the muscle spindle. Muscle spindles are in tendon, and that senses how much muscle is contracting, how much shortening of the muscle is happening when you contract the muscle. And when you stimulate those sensory nerves, reflexes happen, tendon reflexes. So when doctors tap your knee for the knee jerk, for knee reflex, they're actually stimulating those sensory fibers. And by the reflex, it comes back to the motor axon and stimulates the muscle to contract. But there are no pain fibers recognized. Next slide, please. So clinically, muscle damages may cause tenderness first, attributed to the distributive nociceptor sensitization, and then spontaneous pain occurs through the nociceptor excitation and the immunization shot, and maybe analogous to that. The central nervous system receives the pain, namely the brain, usually first starts and recognized by the cortex. And then it changes its circuitry if a pain keeps coming, enhancing the perception of the pain. That is called centralization of the pain. So centralization of the pain, if the pains keep coming, that contributes to two things. One is that changes in the perception of the localization of the pain. We call it referred pain. So the pain may be coming, I feel like coming from outside of the actual tissue damage. That's a referred pain. And in extreme degree, you may have had phantom limb pain, when the pain is perceived as if it's coming from the part of the limb which has been amputated. So the limb is no longer present, but your brain thinks that pain is coming from there. That's a referred pain in extreme degree. And also, centralization of the pain may be relevant to the chronic conversion of the pain. So acute pain may be converted into chronic pain by centralization of the pain. Indeed, in the chronic pain, it may be that the pain is no longer coming from the damaged area, but brain itself may be creating the pain sensation, and as if the pain is still there. So muscle pain in DM2, the characterization was done mainly in 2 papers I listed there, Sorkas and George. The pain was reported in about 76% of DM2 patients. That's a great majority, and pain appears between 20 years and 50 years of age. And pain was the first symptom in about 10% of the patients with DM2. The pain is real, but the nature of the pain is very elusive, variable as well. Subjectively ascribed to, quote, overuse of muscles, unquote, or pinched nerves, sciatica, arthritis, fibromyalgia, tendon pain, burning pain, aching, sometimes pinches and bites. So the description is quite variable, and the nature of the pain is also variable. It could be a continuous pain, it could be a repeated bites, and so that's a very elusive nature of the pain. And the pain is often exercise related, temperature modulated, and palpation induced. If you give a pressure, pain tends to occur and persists. Heat seems to relieve the pain, and cold is sometimes relieved, but sometimes not so received well. But true muscle cramps like a charley horse is relatively rare. And as I mentioned, additional connective tissues, tendons, and other structures like a joint may be perceived as painful structures. And interestingly, 18% of myotonic dystrophy type 2 patients have depression. In contrast, the DM1 patients, about 60%, a little bit less, patients with myotonic dystrophy type 1 has pain. And it's mostly chronic pain, and the pain duration is about 12.5 years in average. So pain was the first symptom in 3.0% in DM1 patients compared with 10% in DM2 patients, and most frequently in the lower back and legs. The age was related to the onset, but not severity of the pain. And DM1 patients with mobility limitations and assistive device, namely walker or even orthosis, they tend to have more pain. And in myotonic dystrophy patients, the frequency was in one series, 60%, as I mentioned. The average pain is in 1 to 10 scale, 10 being the most severe pain you have ever experienced, and 0 means no pain. And the average pain scale is about 4.5, so it's a moderate pain. But some subjects, about 24% of the people with myotonic dystrophy, have very severe pain, greater than 7 in pain scale. We talked about the duration already. Next slide, please. Now, where is the most common location of the pain? This is the myotonic dystrophy type 1 mainly, but it's in, as you can see, percent column, third from the left. Low back is very, very common, but arms and legs and even feet are relatively common, and hands. But the proximal portion, particularly the trunk, except for the neck, is relatively rare. And intensity varies. Again, those areas that I mentioned has a greater tendency of the pain, but abdomen and the chest and pelvis may have a pretty bad pain when it occurs, although it's relatively rare. Next slide, please. What about myotonia? Does myotonia contribute to the pain? I think all of you know that myotonia is generally not painful phenomenon in myotonic dystrophy. There are some other types of myotonic disorders like sodium channelopathy, paramyotonia. They may be quite painful, but in myotonic dystrophy, the myotonia is not so painful. And in animal models, in which only myotonia is a prominent feature, they don't appear to have significant muscle damages. So the myotonia itself may not be damaging to the muscle cells. So muscle degeneration is probably a better candidate for the source of muscle pain than myotonia itself, although whether the muscle degeneration itself or susceptibility of DM muscles to further damage the muscle is main source of pain remains unclear. Next, please. How about exercise and muscle regeneration? As I said, often exercise induces pain in myotonic dystrophy. Too much exercise to try to build up the muscles is not quite recommended in myotonic dystrophy patients because it causes pain. And also it is known that the CPK or CK level, that's muscle enzyme, when the muscle breaks down, that CPK level increases in the bloodstream. And we can see that it's true in myotonic dystrophy patients. After vigorous exercise, CPK level actually goes up, indicating muscle breakdown happens in myotonic dystrophy muscles. But the recovery from that is lousy because you have a genetic disorder of the muscles, so regeneration is poor. In regular training, you actually damage the muscles slightly by intense training. So you have muscle soreness, but regeneration is stimulated by that muscle damage. So your muscles grow, rebound, and you have a bigger, stronger muscles. But in myotonic dystrophy, this rebound recovery is limited. That's the reason why net effect is negative. You do more damage than good by doing too rigorous exercise. So I usually tell the patients with myotonic dystrophy, do exercise so that you feel better, you feel good, and you feel energized. But if you are aching on the later day or next day, or you're so tired you cannot get out of the chair or bed, you're doing too much and doing no good, actually damage to the muscles. Next slide, please. Cholesterol lowering medications. Statins, HMG-CoA reductase, that's official name, can cause myopathy, which may be painful. In myotonic dystrophy patients, many patients have hypercholesterolemia, high cholesterol, and they're placed on statin. And it may cause pain. So if you have to be treated, you have to be carefully monitored about the muscle damage. And again, CPK level may be an indication whether you are having this statin-induced painful myopathy. So please pay attention to your cholesterol medication. Next, please. Treatment of muscle pain. What do you use? This is a survey from a registry of the University of Rochester NIH-sponsored registry. And they took a survey, and interestingly, ibuprofen and acetaminophen, that's a Tylenol, those are most frequently used, and people with myotonic dystrophy continue to use. The average relief obtained is moderate. It's not striking. The most striking improvement can be obtained by opioids, like morphine or OxyContin, etc., etc. But not many people continue to use because it's difficult to obtain a prescription on a continuous basis, and physicians discourage you to use the opioids on a continuous basis. And other things frequently used are Neurontin. This is a relatively mild medications, but effect is 3.10, relatively low. Heat seems to be quite good. Relief is 5.15, and 37% of the people with myotonic dystrophy continue to use that. But ice is less effective. The interesting thing is marijuana. I don't know, it's a Californian study, must be, and Florida, you go to jail. But it's quite effective, and a decent number of people continue to use, so it must be a good drug. And I think cannabinol is scientifically a very interesting drug for pain relief, and I think legislators should reconsider the use of cannabinol in the future. Okay, next slide, please. The abdominal pain. It's a frequent complaint of myotonic dystrophy patients, both type 1 and type 2. And most studies showed hypermotility of the gastrointestinal tract from the esophagus to the rectum. And it causes constipation more frequently than diarrhea. And intestinal pseudo-obstruction is a major problem with a very severe abdominal pain. You go to ER, and the doctors misdiagnose this is an indication for the surgery, and unnecessary surgery could occur, or the patient may be given morphine IV and then going into the trouble one way or the other. Gallbladder, again, it's a gallstone lodged into the outlet of the gallbladder because of the weak muscle, smooth muscle in the gallbladder. And this is also can cause excruciating pain. And again, surgery may be necessary, and morphine and other medication may be given. Again, the same precaution has to be taken. Next slide, please. Here's a megacolon.
Sorry.
That's okay. I'm sorry?
No, I missed the graphics. Sorry about that.
Oh, that's okay. So, colon may become very big, and that's a part of the intestine. It's become very, very big. It's called megacolon, and I've seen in myotonic dystrophy patients quite frequently. Next slide, please. Treatment. So, you can use diet. Diet is important. Fibers is important. Laxative, you can use mild laxative like milk of magnesia or mild prescription laxatives. And sometimes you can use enema. But the liquid paraffin in the US, it's known as a mineral oil, can produce severe problems in the intestine. It can cause a volvulus, which is an actual true obstruction. So it shouldn't be used as a laxative. So avoid mineral oil. The gallbladder surgery may be necessary to remove the gallbladder. And again, we talked about anesthesia already. Pseudo-ileus may be mistaken as a real obstruction. And real obstruction is characterized by radiograph of the abdomen. And it should be readily recognized and differentiated from pseudo-ileus, pseudo-obstruction. And so, but I think you need to think twice if surgery is recommended for the intestinal obstruction. The chest pain could be a cardiac arrhythmias. So we talked about that already. And chest pain could be caused by gastroesophageal reflux, which is a sort of heartburn with a gastric juice, acidic juice going up to the esophagus and give a pain. So this has to be differentiated in emergency when you have a chest pain. Again, electrocardiogram and creatine kinase may be another troponin and other markers will be very important. Okay, next please. So management of the chronic pain. I'm going to wrap up here. The pain negatively affects psychosocial life in myotonic dystrophy patients, and focusing on pain makes a negative effect worse. And I talked about centralization of the pain, and focusing on pain consciously may further change the centralization mechanism and enhance the pain and spread the pain. Coping strategy is therefore very important, and support group can play a major role by talking to other people, and how to cope with the pain will become very important. Next. I'm going to skip this. It's chronic pain and acute pain have very different biological mechanisms. But so pain management should be multidisciplinary. That means you can use physical therapy or OT, pharmacotherapy, we talked about already, the drugs, and neuromodulation, and that is stimulator with, for example, TENS unit or other massage therapy, etc. And neuroablation, this is not usually recommended, but if the pain is really severe, you can cut the part of the pain transmitting pathways, both peripherally and centrally. And cognitive behavioral therapy, like biofeedback therapy, and those things may be used. The spiritual therapy, the question mark, and complementary or alternative therapy may be a good place in the pain management, particularly pain becomes chronic. Acupuncture, for example, or some other herbal medicine, those things may be tried. Next, please. And the controlled substances, if we can avoid, we should avoid those things with obvious reasons. I mentioned about respiratory suppression, and chronic use is a problem in general in terms of the addiction and chronic complication of the drugs. Next, please. So this is from a Croatian poet I can't pronounce, Dobrica Cesaric or something like that. I don't know if among audience, if the Croatian person, I apologize for the right pronunciation. But some walk with their pain like an open wound for all to see. The others crush it into themselves and do not let it turn into tears and wars. That's a sort of a very interesting prospect of the pain perception, and it has to be, management has to be individualized, and we have to make empathy and the recognition of the pain, and then we have to use the right strategy to let the patient cope with the pain. Next. So those are the website I took pictures from, and there is substantial information about each subject. Okay, that's it. Thank you very much for listening. Question time.
And we have some questions for you. Are you ready?
Sure.
Okay. What if you take morphine in small doses orally, for example, 30 milligrams MS 3 times daily if necessary?
Yeah, it's again, if necessary, you can do that. Oral medications are safer. Now, addiction is a problem, but I think addiction is also depends on the individual. Highly addictive people, I think there are some traits, some of them may be genetic. And that, for example, smokers who cannot stop smoking, or compulsive gamblers, or alcoholic people tend to do worse with the morphine oral treatment. They may be escalating the doses, and they may get into problems. And regular over-the-prescription analgesics or sedatives, you see the Michael Jackson's case. And so those things are not necessarily the patient's fault, but patients are more susceptible to the chronic medication with the dependency. But if you can get away with intense treatment with morphine with acute pain, and you can stop that and nothing happens and you're not addicted, you're a lucky one. You're not addictive body nature. And in that case, you can wisely use morphine and other drugs. And the low dose chronic morphine, you can get away with it. I think that's fine, but you have to be under the care of a pain specialist, and they can provide the prescription wisely with appropriate monitoring.
Okay. The next question. What is neuromodulation and neuroabrasion?
Okay, so neuroabrasion is a cutting the nerve. For example, if you have excruciating pain in a limited part of the body, you can actually do the rhizotomy, which is cutting a part of the proximal part of the nerve, and the thalamotomy, that's cutting the thalamus. It's in the brain. It's a brain surgery, and a number of different things have been done. And deep brain stimulation may have some application with that, and so that's a new operation. And the neuromodulation is again stimulation of some sort. The most commonly used one is a transcutaneous um, electrical stimulation. It's called TENS unit, and that stimulates a part of the nerve that suppresses the intensity of the pain, and that is very effective in some individuals. Some individuals do not benefit at all. But since side effect is almost none, and it's relatively inexpensive, so that that kind of therapy should be tried in some individuals.
Do you agree that severe untreated pain causes DM1 patients to have severe depression?
Oh yes, there is no question about that. So pain, particularly chronic pain, creates no-win situation. And if you lose hope, you certainly get depression. And so that's a vicious cycle, and you cannot get out of that bad cycle. And you need a consultation with a pain management doctor as well as a psychiatrist.
How safe is it to use over-the-counter Prilosec for chest pain or GI reflux?
Well, I think it's not bad. I think it's widely used medications. As far as I know, there is no adverse effect except for the usual labeled, side effects that when you buy the drug. I don't think there's any special precaution for myotonic dystrophy. Now, suppressing the pain is a relief, but at the same time, if there is a significant underlying disease, it can mask that disease progression. And so when you take those medications, and if a pain doesn't completely go away and become chronic, I think you should seek the medical professional advice and go to see a doctor.
Okay, this next question, the person is asking specifically for DM2, is elective anesthesia also dangerous, such as what's used during a colonoscopy?
Very good question. Now, DM2 patients have, in general, believed to have much less susceptibility for the respiratory suppression. Indeed, case reports are almost non-existing, and the systematic studies are lacking. So I can't really say with confidence that you're safe, but I think your alarm rate, level should be much less than if you have myotonic dystrophy type 1. But I would tell, for the anesthesia, I would tell anesthesiologists or GI specialists to go easy on that. And I usually think it's a good idea that if you have a dental procedure or colonoscopy or something like that, at least the anesthesiologists are sort of a standby. They don't have to be in the same office, but if you're going into the problem, they can come and take care of the situation.
We have another question from someone with a young person with DM2 who tries to avoid opioids, although he takes Gralise, gabapentin ER, and tramadol. He gets severe pain in his large muscles and low back. How effective can physical therapy be?
Yeah, so I think in terms of the centralization of the pain, physical therapy, appropriate physical therapy may be effective to prevent that. There's a large literature in fibromyalgia in the centralization of the pain. Now, DM2 pain is similar, but not not really the fibromyalgia pain. So I don't know if those data apply to DM2 pain. But indeed, interestingly, I believe it was a German study, and if they look at fibromyalgia patients and do the EMG, about 6% of fibromyalgia patients also have DM2. And so DM2 may be a cause of fibromyalgia in a small fraction of the fibromyalgia patients. Now, so if you apply that kind of analogy, the physical therapy may be good to prevent centralization of the pain, but still I think it's yet to be seen. And you need to go with your instinct, empirical, sort of based on your experience, what to do. But I think sedentary, being a couch potato is not necessarily good. Particularly when you're getting older, you're a young person, so that it may not apply. But when you're sitting on the couch all day, when you stand up, it aches here and there with muscle pain. As I think mobilization is important component of the management of the pain.
We have another question from someone with DM2, and I want to ask about this for DM1 as well. And she wants to know about non-drug strategies, and you talked a little about that, but she's specifically concerned about or interested in diet and exercise as strategies for pain.
Yeah, absolutely. I think you are what you eat, right? And so diet is always important, and but exercise is even more important. And if you can maintain your physical activities, that's number one, good for your general health. If not, it's good for your pain management. So that I think it's important. Just because you have pain, if you become very inactive, that can cause a lot of problems, confounding problems, and as well as it doesn't serve for the any good for the pain either. So I think just enough exercise, mobilization is really important. A diet, what kind of diet you should be on for the pain particularly, I don't have real good idea. But I think if you look at the alternative medicine literature, for example, calligrain and pepper substance and other things have been used for the pain management, and there are certain diets associated with the pain management. And I'm not an expert in that area, but you may consult to the experts on that one.
So we have just a couple more questions. I know we're going a few minutes over. Is that okay with
Sure.
you? Okay. We have a question from someone in Europe who wants to know the best way to inform an ER about his medical condition. If he came in unconscious, he doesn't trust that a staff would check his pockets before sedating him.
Yeah, so there's a medical bracelet or medical necklace, that kind of things would be useful and to inform the ER person. Now, however, just it says myotonic dystrophy, it doesn't ring a bell to the ER physician or nurses because they don't know much about it in the medical school. You probably learn no more than 10 minutes of myotonic dystrophy. So you are much more knowledgeable than average doctor about myotonic dystrophy. We try to change that by incorporating myotonic dystrophy in the medical curriculum with more attention. But sometimes it's not possible in some circumstances. So I think there are some form, the piece of paper you can carry in that all the essentially necessary information that was originally developed by myotonic dystrophy support group in the UK. And Margaret Bowler, whose husband had myotonic dystrophy, and her son is an anesthesiologist. And so they developed this very clever, intense information in one page, and you can downloadable. I think MDF also has a link to it. And it's not a bad idea to carry that. Now you're unconscious that people may not really look for that kind of piece of paper. So that may be a problem, but at least medical bracelet and necklace and that kind of stuff would be useful.
Okay, one final question, and you did sort of touch upon this. Someone wanted to know your thoughts on acupuncture.
Yeah, it's interesting. I think um, you know acupuncture. There are some literature, the specific pain pathway and pain receptor may be altered by acupuncture, but on the other hand, there's a large literature saying that yes, acupuncture does something interesting, but so does placebo acupuncture. So if you stick the needle into chi spot, I'm not acupuncturist, so don't take my word. Okay, this is out of my expertise. This is a disclaimer. But if you stick outside of the chi, it's not supposed to be effective, but it's effective. It's a placebo effect, and placebo effect with acupuncture seems to be pretty good, actually. But if you put in the chi area, it's slightly better. And so I don't know if it's statistically significant or not. And they in fibromyalgia literature, the chi spot is often coincide with the trigger spot, which is presence of trigger spot is a requirement of the diagnosis for fibromyalgia. It's a diagnostic criterion. So there may be something going on very interesting. There have been functional MRI studies when you stick the needle of acupuncture. Let's see what happened to the brain metabolism. And there are some interesting results there as well. But I would say if it works, why not? Acupuncture does not give you any horrendous side effects. And I have taken for my knee pain from my brother-in-law who is acupuncturist. I was very skeptical, but placebo effect or not, I feel better. And if you feel better, why not? I mean, placebo is wonderful if it's effective.
Well, thank you so much, Dr. Ashizawa.
Sure.
This has been a very helpful presentation. I'm going to just go over a few things before we end officially. I'd like to invite you all to join us for our next webinar on November 19th. It's on being a fearless caregiver. And if you haven't registered, of course, there's still time. We have the URL up here on the screen to register for that. Each webinar you have to register for separately. And we have a warm line. If you have any questions or family members have questions or you need some sort of resources, you could fill out a form, a warm line form at this URL. And that's it. I want to thank you all for your participation. This session was recorded and it will be on the MDF website in the next couple of days. Thank you.